Welcome to the Clinical Examination Tutorial Series. My name is Dr. Brian Benninger. I work here at Oregon Health and Science University. Today we'd like to talk about the cranial nerve examination. Generally this examination should take 5 minutes, often referred to as the modified cranial nerve examination. I'd like to start off by thanking our volunteer patient, future clinician, Dr. Hudak. All right, we'd like to start off with the olfactory nerve, the first nerve of the 12 cranial nerves. And with that, there's a sense of smell associated with that. And the first thing one likes to do is ask the patient to go ahead and close their nose and block off one nostril. You waft the scent underneath and ask them, what do you smell?
Coffee.
They smell coffee, and then you repeat that and ask them to then block off the other nostril, waft the scent underneath,
Coffee.
and ask them what it smells like, and indeed it was coffee on both occasions. And from that, you would then move on. However, if it was altered, if she happened to say one side was slightly different than the other, then you would come up with 3 classic questions. But before those, just be aware, why did we choose coffee? And one of the things in this world where people can travel so easily from one continent to another, or another part of something within the continent, you want to be aware that you need to use a universal smell. 2 classic universal smells are coffee and something citrus, generally orange or lemon. And most places, wherever you go in the world, people are familiar with coffee and something citrus. Now, if there was something altered in that, I would then follow it up with, my first question next would be, are you a smoker or have you just recently stopped?
No.
Okay, and that's probably the commonest cause of altered sense of smell is someone who smokes. The next one would be, have you recently had a cough or a cold or sinusitis, any type of upper respiratory tract infection?
No.
Okay, and then lastly I would ask, has she been involved in any sort of trauma? Has she been involved in a motor car accident, fallen off a bicycle, skiing accident where she had a concussion or a head injury?
No.
Okay, those are probably the 3 most common questions you'd like to ask whenever you think sense of smell has been altered. We would then like to move on to the second cranial nerve, the optic. Now with that, you would look at the patient, and the first thing you start with is just to examine the eyes themselves from a symmetry point of view, and we look at the pupils. We want to see that the pupils are equal. Majority of the population have equal pupils. However, there are some people within the population who have unequal pupils, and that's still within normal range. And that's terribly important because imagine if someone did have some trauma, they've come into an emergency room situation, and someone looks and says they've got unequal pupils, and suddenly scans and various things are organized when it may have not been appropriate. So it's very important that that documentation stay with one's patient. First thing I'd like to do is just let them know that I'm looking at both pupils, and most pen torches that we use today will have some sort of grading system on the size of pupil. It's probably not as important as to say that they're either equal or they're not equal, and saying that the right is either smaller than the left. Okay? But a lot of these will have a grading system on them, a size 4, size 5, etc. The next thing is I'd like to say that we're going to shine a light in your pupils to see how they react. And that's very important that you get a pupils and how equal and reactive they are to light. Now, this technique can often be a little bit aggressive for the patient. In other words, sometimes beginning technicians or examiners will come in directly from the front with the bright light. And remember that whenever we turn on these pen torches or lights here, there is a peripheral, very softer light, and then there's a central, very bright light, much more acute. And so what we don't want to do is come in very aggressively. It's a bit off-putting, and it just doesn't set a good scene for the rest of the examination. So what one wants to do is just come in from the side and tell them to look straight ahead. And I like to just start and just show them just briefly the very soft light, and I watch the ipsilateral or the same side pupil and see how reactive it is. And I do that twice. The second time, I do it on the same side here, but I'm actually looking at the opposite pupil, the contralateral pupil. Once I do that, I then switch hands, and I come in from the side, and I do the same thing twice. Once looking at this side and watching the pupil and observe that. Once on the opposite side, i.e. the ipsilateral and contralateral sides. Once that's been done, you would record that, and then you move on to the second portion of that same cranial nerve number 2, and you're going to check for the red light reflex. I generally like to get a hand's breadth apart, and you then use the same eye. So if it's the patient's left eye, you would then hook up the the ophthalmoscope to one's left eye, have a look, make sure you can locate that red light reflex, and then let the patient know that you're going to be examining them and you will come in very close quarters with them and tell them not to be concerned about that. When one comes in, they get in very close here, and what you're looking for is the disc. You're looking at the vasculature or the vessels, making sure that they all look terribly healthy, that you don't see copper wiring or cotton wool spots, indicative of perhaps hypertension, and various other things. You want to have a close look at that. Now, from there, you can do visual acuity. Generally, you would use a Snellen chart, but when you're doing a modified cranial nerve examination, and you're in your office or someplace like that, emergency room, you find something that's, you know, relatively about 18 feet away, and you could ask them to say, could you please read what's on that poster there?
Sky Eye Camera.
Right, and you read that and you want to double check and make sure, you know, do you normally wear contacts or glasses? If so, have them wear their glasses or contacts while they're reading, document that, and you would move on. From that point, you would then go to peripheral vision. And now with peripheral vision, you've got to be a little bit cautious about that. People tend to be relatively competitive when you ask them to assess themselves. Now with that, I like to look straight on with the patient, and from that I would say you test the upper and the lower zones on both sides. Now what I'd like to do is, the classic problem is if you say, let me know when you see my arm moving, the moment I would move, the patient, if they're really competitive, would say, I can see that right now. I can tell that's in my peripheral vision. What I like to do is move my arm, but also then say, don't say that you can see myself until you see my fingers moving. And so these are my fingers moving, this is just my arm moving, okay? So I usually like to, for the first time, just move my hand or my arm without my fingers moving, just to see if they're truly paying attention. So you ask them to look straight ahead, not look at your arms or your hands. Start out here as far and back as you can go, so that you know you're out of their peripheral vision, and then start to bring it in. Okay, yes. And she's recorded that she can then see it. I've assessed that. I go down to the lower area. I then come in.
Yes.
Okay, and you would do that on the opposite side as well. And that's just assessing that peripheral vision. And again, be cautious how you do it, because people want to be terribly competitive. The last thing I do is accommodation. And generally what happens is one takes their finger out here, again about a hand's breadth apart, and you come in directly right down at their nose. And I always save that for the last, because some people are so sensitive that you do that, it can trigger off a type of nausea, or even in some people perhaps they may actually get sick. To do that at the start, I think, would be very antisocial, and it's best to do that at the end of that eye part of the examination, so that then you move on to the next portion. Okay? Welcome to the Clinical Examination Tutorial Series. My name is Dr. Brian Benninger. This is a continuation of the cranial nerve examination. We will now continue with nerves 3, 4, and 6. Before we actually start that, I'd just like to let you know that whenever one examines the nervous system, whether it's cranial or a peripheral nervous examination, the key is to stress the system. And if one doesn't stress the system, you're not going to get value for money, and you will miss subtle signs. So with cranial nerves 3, the ocular motor, 4, the trochlear, and 6, the abducens nerves, these have to do with moving the globe or the eyeball within the orbit. And so these have to do with movement of the eye itself. And for this, we classically talk about creating an H pattern, the pattern of an H. So most people would sit in here like this and create a very narrow, tight H, okay? And I have a problem with this, because this will not pick up anything terribly subtle, okay? It's going to be a small, tight H. Those eyes aren't going to do a whole lot of movement. And what you want to do is pick up those subtle things. Anything that's terribly obvious, you're going to pick up on just general examination. However, with this, you need to stress the system. So what I like to do is start with my left, and I would start in the midline and about the equator, about the level of the eyes. Ask the person just to follow your finger. Come straight out, keep going as far as you can go, and then go up high into the top corner up here, watching those eyes, really working those eye muscles. Come down to the lower portion here, come back to the equator or the midline, and then switch hands, because you will be staring straight on at the patient, and then use your opposite hand, go to the far side with an equator or the bar of the H, go all the way to the top, and then come right down to the bottom, bring it back to the midline and stop there, and you will pick up subtleties. If you're fatiguing muscles in myasthenia gravis, that you will start to see that. You will be able to see obvious nystagmus, and whether it's vertical or horizontal. These things will become much more obvious if you stress the system. So for cranial nerves numbers 3, 4, and 6, oculomotor, trochlear, and abducens, one wants to stress the system and create the large H, okay? Now, from there we will move on to the cranial nerves number 5 and number 7. Number 5 is the trigeminal nerve, and the trigeminal nerve is a predominant sensory cutaneous nerve and with some unique motor aspect to it. To start off, what we want to do, and this is again a very important technique, is we know that the trigeminal nerve has the 3 parts, an ophthalmic, a maxillary, and a mandibular portion where nerves come out to innervate these 3 classic regions on our face. All right? One of the things that people often do is they'll put their fingers, their fingertips, and they'll touch both sides here, and they will pull to the side like this. What that does, in my opinion, is the quality and the way that my fingertip is, the oiliness and the texture of my finger is going to be different than every patient that I see, and vice versa. And so if I'm to press, and I might press differently, and if I pull, I'm actually stretching skin. And so from that point of view, if I said, does it feel the same on both sides, it would be very difficult for a patient, especially a very competitive patient, to say, well, perhaps the right is a wee bit different than the left, okay? But you're not getting a very accurate statement there. So what I recommend is to use the back of the nail. So it doesn't really matter the type of skin that you're examining, whether it's terribly oily, terribly dry, or anything in between. You use the back of the nails and you sweep across in this manner. And I always do it twice. The first time, almost so that they can get a feel of what I'm doing, and the second time is when you actually ask them, does it feel the same on both sides? You don't say is one completely absent of sensation. That would be terribly rare. But there can be differences. And so one wants to start off by saying, does it feel the same on both sides?
Yes.
And then you would come down and do the maxillary portion.
Yes.
And then start here in the mandibular portion.
Yes.
Okay? And again, using the back of your nails, so therefore there's no pulling on the skin and differences. Now, I'd like to just talk about briefly, we know generically that this would be V1 is the ophthalmic, and this is the maxillary and the mandibular. Again, one of the problems is when we examine, we tend to just go a short distance, maybe to the edge of where the eyebrows finish right here, and then our hands slide away. Don't forget that, people, their head continues going around in a contour. So what one wants to do is actually follow it around, and I like to come right past and close to the ears. Now, with that in mind, you have to raise your level of understanding about the nervous innervation. From the first part until we probably get right to the angle, right where the eyes would finish right here, we're truly doing the supratrochlear and the supraorbital coming across here. Those 2 nerves are part of V1, okay? But if I continue around here, as soon as I get in this area right in here, the start of that temporal region, one almost certainly is getting the zygomatical temporal nerve, which is part of V2, and then if I continue and go right up close to the ear, I'm now actually getting the temporal part of auriculotemporal. So really with this particular examination, if I go all the way around, I'm actually doing V1, now V2, and then now V3, okay? So we're actually doing V1, V2, V3 if we're being totally comprehensive. But if we were to stop right here, that clearly would be V1, okay? But when you do the examination, maximize your opportunity to go all the way to the ear to figure out where the subtlety would be. When one comes down to here, clearly at the start, this is all going to be V2, but it'll be the infraorbital nerve. We will then have a buccal nerve in here. Again, that will be part of V3. And so remember that, again, this is V2, but then some area, some part of this could be V3 from the buccal nerve. Initially, infraorbital, a bit of buccal, finishing off by the ear there. When we get down to the mandible, we would then go and do, obviously the mandible would be the mental nerve coming in through here, perhaps a little bit of buccal as you go back, and you would finish off there. And that would be those 3 nerves, and that would be the sensory component of the trigeminal, okay? Now the motor component of the trigeminal, we use muscles of mastication. Initially, you want to assess any type of muscles with power, with gravity, and against gravity. So I just ask the patient to go ahead, open and close your mouth. Now, by closing it quite simply, I know that she can work her muscles or her mandible against gravity, so I know that she's at least at a 3 out of 5 on that type of scale. From there, I would ask the person to waggle their chin from side to side. Then I know particular muscles such as the pterygoid, medial and lateral pterygoids, are functioning. And then I would ask to assess a little bit more there as far as the strength of these muscles. I generally ask them to go ahead, and I put my hand on the top of the head here, ask them to open the mouth, and then go ever so gently so you don't collapse the teeth together to create some sort of a fracture, but actually say, I'm going to give me some resistance, don't let me close your mouth, don't let me close your mouth, okay? And if you have an element of resistance, you can easily go to a 4 or 5 out of 5 right there. Now, again, one of the techniques that I think might be difficult to assess is if you have them close their mouth, put your hand right here and then say, open it against this resistance. That can be very tricky, especially in the elderly. I think it's much better to have them open it and then gently see how much you can close it. And so that would assess the motor part. The last bit on that is sometimes you can put your hand on one side and say, press against it with your open mouth. Okay, opposite side, move your, okay. So you're just assessing where there's movement from side to side there, okay? Now, that would be the trigeminal completed there. Facial nerve. The facial nerve is a motor nerve, a very strong dominant motor nerve for the muscles of facial expression. With that, you start off, and I like to give the example to the patient. If you ask them to furrow their brow, show them and do it for them, and then ask them to repeat it. Okay? Then I ask them to screw their eyes up tight, and I show them what I mean by that. So screw your eyes up tight, and then I say, don't let me open them. So they close it tight, and then you try to pry it open. You say, thanks very much. There are some people that might have damage to one of the facial nerves that would come up, maybe do the orbital part of the orbicularis oculi, but perhaps the palpebral part isn't as well stimulated, or a different nerve got damaged there. You may be able to open those up quite easily and therefore index a suspicion that there is injury to part of the facial nerve because of the crossover of what's going on with the facial nerves. Now, once I've done that, I would then ask them to blow their cheeks out. Don't let me push them in. Okay, very good. So there's some resistance there and able to maintain that. Okay, and then I'd ask the patient to smile. Okay, show your teeth. Very good. Sometimes they can smile and have a problem, but if they have to show their teeth, it's more control about those muscles around the mouth. And so that part is very good. And then that would control, if you like, part of buccal, part of the marginal mandibular nerve. And then as we went down to the very last nerve, or the nerve coming inferiorly, the cervical nerve or cervical nerve, one would ask them to make like a frog's neck. Go ahead, there you go, jolly good. And so then you know that the platysma is being stimulated, and therefore those 5 classic branches, that being the temporal going to the frontalis. Remember, the temporal isn't going straight up vertically, it's coming over to the frontalis, and then often giving off branches towards the orbit region. Then you have the zygomatic nerve, again, maybe helping with the frontalis, certainly covering this region around the orbit of the eye, and then one has the buccal coming centrally over here, giving help above and below towards the equator of the mouth. And then we have the marginal mandibular coming along here, again working some of the muscles down in the lower part of the face here. And then lastly, that cervical one coming down into the neck and helping with that platysma in its stimulation. That will conclude those cranial nerves. Thanks very much. Welcome to the Clinical Examination Tutorial Series. This is the continuation of the cranial nerve examination. My name is Dr. Brian Bellinger. I work at Oregon Health and Sciences University. And we want to continue with cranial nerves 8, 9, 10, 11, and 12, that being the vestibular cochlear, glossopharyngeal, vagus, spinal accessory, and indeed the hypoglossal nerves. Now, to start with the vestibular cochlear, there's 2 parts to that nerve, the vestibular portion and the cochlear. And the vestibular portion has to deal with balance. So with that, you would ask the patient, or you could have watched them when they walked in if you had that advantage to see them walk in. If not, you would ask the person to get up, walk a few steps, 4 or 5 steps, have them turn and come back. Focusing on the turn. The turn is really quite difficult to execute if you've got some sort of vestibular problems, okay? So focusing on that, that would be the vestibular portion. Now the cochlear portion is for hearing. Now with that in mind, you don't need elaborate sorts of tests, but you want to be aware that some people can lip read very well if they're compromised and spent years of practicing that. And so what one wants to do is 2 things. Either gently rub your fingers together and say, tell me when you can feel my fingers rubbing, and you may not rub them obviously and to see what they say, or you can lean past their vision, their peripheral vision, whisper something in the ear and ask them to repeat it. So you lean past them, whisper something ever so quietly, come back and say, what did I just say to you? And you might say, Mrs. Brown lives on Main Street, or something of that sort. So you have 2 options, either using the movement of the fingers. Now, 2 other tests that people often do for bone conduction, okay, is to use a particular tuning fork, the Rennie's test or Weber's sign, which one would hit the tuning fork and either press it on the mastoid process on both sides and ask them to see when they actually can hear the tuning, or I should say feel and hear the tuning fork, and indeed when you do the test on the vertex of the head. Now, from there, one moves on to the 9th and 10th cranial nerves are examined together, the glossopharyngeal and the vagus. Now, classically what happens is you ask the person to open their mouth wide. Usually you would use an orange stick or some sort of a utensil that you would use clinically, and you would introduce it into the mouth, press on the back of the pharynx, and what you're assessing, and you shine a torch in there, and you're assessing for the gag reflex. Now, one of the things I think is overrated is indeed the gag reflex, because is it terribly important to recognize that? Yes. If one normally has one and they lose that, then that's a terrible problem and can create enormous problems for the patient and for the treating clinician. However, there are people in the population who don't have a gag reflex, and so therefore it's important that we assess that. Now, to be able to pick that up doesn't take a very acute clinician. However, what is terribly important and what you can maximize from doing this examination is actually when you do the gag reflex, watch for the soft palate, the palate in the back there. When you look at it, make sure that during that gag reflex that you watch to see if that it lifts or rises symmetrically. At times what can happen is the right or the left side will lift quite aggressively and the other one will follow behind, and therefore you'll pick up a subtlety that indeed those particular nerves are not working functionally to help that soft palate lift. And so I think the more important part to pick up, you'll notice the gag reflex or the absence thereof immediately. The key is to actually look at that soft palate, okay? So with that in mind, we move on to the 11th cranial nerve, the spinal accessory nerve. Now, the spinal accessory nerve, its target organs are the sternocleidomastoid muscle, coming from the ear down towards the clavicle and the sternum, and indeed going to the trapezius. So, two aspects to this to be comprehensive. Ask the patient to go ahead and elevate their shoulders, and then put them down. That would be called a shrug, if you like. And the fact that this particular person can do that tells me, muscle-wise, on a power scale, there's 3 out of 5. Okay? Now I would ask the person to do it again, and say, do not let me push your shoulders down. And so I would press fairly gently at first, more aggressive, and then relax, knowing that she resisted quite appropriately, and therefore 5 out of 5. Now, again, one of the problems I feel when you have quite elderly or people who are, shall we say, very petite, that is to start down low and press on the shoulders and then ask the patient to lift them up. Sometimes can be very awkward and very difficult to do, and also I find very difficult to assess where that power is at. But if you have them lift against gravity, go ahead, and then you say, now don't let me push them down, you can get a feel of one side drops before the other, that sort of thing. So that can be very helpful. Now, the second portion, the sternocleidomastoid, again, I have them turn their head right to left, okay? Sometimes you can ask them to place their ear down towards their shoulder on either side. Now, generally to examine it against resistance, you place the back of your hand right against their cheek and ask them to turn aggressively that direction, okay? And then you do it on the opposite side. And you're assessing the strength there on the sternocleidomastoid as well as trapezius, okay? Once you've done that, you then move on to the 12th cranial nerve, the hypoglossal nerve. And again, there's an element of technique that you can be fooled by. Now, sometimes you ask the patient to go ahead and stick your tongue out and then leave the mouth closed. Go ahead and stick your tongue out further and leave the mouth closed. Lips around the tongue. Okay, so what can happen is you'll ask a patient to stick their tongue out, and they may do exactly what our patient is doing here, and that is it's protected by the lips, and therefore I'm not seeing any movement of the tongue, and you'll be fooled by that. What you should do is say, please open your mouth, stick your tongue out, and make sure that their mouth is so open that indeed the tongue is not being controlled by the lips themselves. Now you wait about 15 to 30 seconds, which will seem like an eternity, and you watch the tongue either for fasciculation, which is a type of, if you like, just wiggling or jiggling about, or with a bit of time, if it starts to drift to the right or the left. Classically, if it drifts over to the right, we know they have a right-sided lesion affecting that particular hypoglossal nerve, or if it drifts to the left, it's a left-sided lesion. Now, again, it takes a little patience. Ask them not to control their tongue with their teeth or their lips. Wait a little bit longer than what you might expect. You wouldn't just ask them to stick their tongue out and then say, okay, fine, and they retract it. Have them leave it out for a short while, assess and see what happens. That's being 15, 30, 45 seconds, and look for fasciculation or movement. Again, why do we do that? Because we want to stress the system. If we don't stress the system, we will miss the subtleties. All right? So the take-home message with the modified cranial nerve exam is make sure that you stress the system, and don't be afraid to ask a couple of appropriate questions that go with each cranial nerve. Thanks very much.